Yeah, when you're done, just pause if you want to. Or you just escape and then end the meeting. Okay. And you're good. Okay. Oh, I need to run that again. Yeah. If I go here. Share that. Okay. So it'll show up on the screen. Yep. All right.
Good afternoon. I'd like to call the March 21st, 2023 Health and Human Services Committee of the Board of County Commission to order. First order of business is to introduce ourselves. My name is Arthur Griffin, and I'm a commissioner at large. I'd like for the commissioners who are on the committee to introduce themselves. I'll start with to my left.
My name is Vilma D. Leak, and I represent the most powerful district in the county. And those of you who are guests, welcome.
Thank you, Commissioner Leak. I'll go to my right.
Good afternoon. I'm Laura Meyer, and I represent District 5.
We also have a colleague who's here visiting because we do such a great job. Like for my colleague, Commissioner Rodriguez, introduce yourself.
Thank you, Mr. Chairman. My name is Susan Rodriguez McDowell, elected by the people of District 6.
Thank you so much. I call on now the executive team to introduce themselves real quickly since they got 5 minutes on the clock. I'll start with the Deputy County Manager.
Good afternoon, Anthony Troutman, Deputy County Manager.
Good afternoon, Raynard Washington, Public Health Director.
Good afternoon, Stacy Lowry, Director of Community Support Services.
Good afternoon, Jacqueline McKnight, Deputy Director for the Department of Services, Social Services, and the new Department for Child, Family, and Adult Services.
We have some other subject matter experts in the room.
Good afternoon, I'm Yolanda Griffin, Director for Department of Community Resources.
Hey, good afternoon, everybody. Robert Nesbitt, Chief of Staff for the Consolidated Human Services Agency.
Good afternoon, Taya Cruz, Assistant to Deputy County Manager Trotman.
And a host of others.
Good afternoon, I'm Lynn Martin. I'm a Social Services Manager at the Economic Services Division.
Good afternoon, Kimberly Conyer, Social Services Manager in the Economic Services Division.
Good afternoon, Broderick Knight, Deputy Division Director for the Economic Services Division.
Good afternoon, Sandra Durham, Deputy Division Director for Economic Services Division.
Good afternoon, Starla Tanner, Intergovernmental Affairs Manager.
Good afternoon, Eliza Durfee, Senior Strategy and Planning Analyst with Strategic Planning and Evaluation.
Hey, good afternoon, everyone. My name is LaShonda Hart. I am the Affordable Housing Program Manager. Good to see everyone.
Good afternoon, Monica Allen, Strategic Planning Evaluation Director, County Manager's Office.
Thank you so much. Turn my mic on. Thank you so much. With all that subject matter expertise in the room, we should learn a lot this afternoon. First of all, I'd like to ask for a motion to approve our minutes from the
So moved, Mr.
February
Chairman.
21st meeting and from our field trip. Valerie Woodard, we have a motion, and the motion has been seconded. Any discussion? Hearing none. All those in favor say aye. Aye. The motion passes. And I'd like to turn to the Deputy County Manager, Anthony Trotman, to introduce this Medicaid overview and expansion. The reason why Medicaid is front and center. If you've been reading the newspapers lately, you know that the General Assembly is about to pass Medicaid expansion. And you also probably heard that our president will call for an end of the emergency, and that will also have implications for us. So this is a very important topic that we will be hearing about and reading about in the news. So, Mr. Trotman, please take it.
Well, thank you, sir. And I think you introduced the topic very well. It was important for us to make sure that the HHS committee was educated on Medicaid and all the complexities of it. And we have two of our great leaders out of Economic Services to give you an overview of the Medicaid program, as well as going into Medicaid expansion. And preceding them, we'll hear from Starla Tanner to give you an update on the current status of the legislation around Medicaid expansion. Then following that, Robert Nesbitt will give you an update on Medicaid managed care and all the different plans that the state has contracted with to deliver services. So I will turn it over to our two presenters, Social Services Managers, Kimberly Connor and Lynn Martin.
So good afternoon, County Commissioners, Deputy County Managers, Director, staff, and guests. I'm Lynn Martin. I'm a Social Services Manager with Economic Services Division. I specialize in adult Medicaid. And
I'm Kimberly Conyer, Social Services Manager with a specialization in the Family and Children's Medicaid.
And we want to start off by saying thank you for inviting us to this meeting. We all know how critically important.
Just a little bit louder, thank you.
Yes, how critically important Medicaid is. And so we appreciate this time. We're going to do a big overview of Medicaid. But if you just think about what it means to customers, if they can't get a prescription, if they can't go to the doctor, what typically happens, or what often happens, what too often happens, is they end up in the emergency room with worse health outcomes. And so we tell our staff routinely, and I imagine many of you around the table that also help with health coverage, tell your staff maybe in a little bit different way that they are life changers, life sustainers, and life savers by the very nature of their work. They make a huge difference in our community. And so Kim is going to jump us off, telling you a bit more about the work we do each day.
All right, so we'll be presenting today on the basic eligibility for Medicaid, the ending of the public health emergency, and Medicaid expansion. So who may potentially receive Medicaid? Those that are age 65 or and older, blind or disabled, infants and children under the age of 21, pregnant women, low-income individuals and families, and those in need of long-term care. Also, those receiving Medicare are potentially eligible. Some of the basic eligibility requirements that cross both adult Medicaid and Family and Children's Medicaid is that you need to be a US citizen or show proof of eligible immigration status. You need to live in North Carolina and show proof of the North Carolina residency, have a social security number, or show they've applied for one. And as these programs are for low-income beneficiaries, eligibility is based in part on income and resources. At the bottom, you'll notice that we also have an emergency Medicaid. This program, you do not need to provide documentation of immigration status for, and the full definition of emergency services is at the bottom of the slide. But to summarize it, it includes labor and delivery or treatment of a sudden onset of medical condition that without treatment, that would result in serious health to the patient. Adult Medicaid will be covering them.
All right, so I want to talk a little bit more specifically about adult Medicaid. So this is assistance to individuals that are aged, disabled, and or blind with their medical care. Now, this type of care can range from us just assisting with their Medicare premiums if they're getting Medicare, all the way through if they're in a nursing home, paying for that coverage. Now, potentially eligible customers are those that are disabled, and I'm going to define disabled in the next slide, blind at any age or 65 plus, and then we consider that aged. Oh, let me advance the slide. Okay, so the definition of disability, this is the same social services standards. So if someone comes in and they don't qualify for Medicaid as aged, and they're saying they are disabled, this is the question that they would need to say, yes, I meet that standard of disability, right? So it's a physical or mental impairment which prevents an individual from engaging in substantial gainful activity and which lasts or is expected to last 12 months or is expected to result in death. So they say yes to that, and then we help them complete some forms. So there is a history, social history form. It's basically going to ask all the medical questions. It's going to ask about education. It's going to get an authorization to disclose information. We're going to send that information up to Disability Determination Services. It's with the state. The state is going to deem whether they're disabled or not within 70 days. And then they're going to send us that information. And we're going to process that case in 90 days. So that's if somebody needs to be deemed disabled, they haven't been deemed disabled prior, or potentially they need an earlier date. So maybe they got declared disabled, but they need a start date earlier than what they were determined before. Now, what types of Medicaid? There's lots of different categories of Medicaid, but we can have Medicaid for the disabled, for the aged, for the blind. Now I have full coverage here. You may say, what does full coverage Medicaid mean? Well, so we're talking about hospital bills, doctor bills, prescriptions, vision, dental, x-rays, blood tests, home health, medical equipment, all those kinds of things. But I tell you, in the Medicaid manual, it's like 62 pages of things covered, restrictions, prior authorizations, lots of things. But that's basically full Medicaid. Then you have partial Medicaid. And when we talk about partial Medicaid, we're talking about premiums. So like help with those Medicare premiums. You have dually eligible people. These are individuals that qualify for full Medicaid. So maybe they're disabled, aged, blind, and they have Medicare. And they fall into a category where we help them with their Medicare premium and they get full Medicaid, or we help them with their Medicare premium and co-insurance and deductible, and we help them with their Medicaid. Then you have long-term care. So this is people in nursing homes, and we help with that cost of care. Then you have special assistance. On the slide, it says for the disabled, it's also for the aged, for the blind. And when you get special assistance, you automatically get Medicaid. Now, when you're out in the community and you talk about Medicaid and you specifically talk about adult Medicaid, you might hear something about reserve. And what they're talking about reserve is assets. How much can I keep and still qualify for Medicaid? Well, the short answer is it ranges, right? It could be as little as $2,000 when we total everything up that we count. This is not an all-inclusive list. This is just some of the things that we count. So you got bank accounts, right? Boats, cash on hand, campers, not used as a home site, investments. So you got savings bonds, stocks and mutual funds. That is not all inclusive, and there's lots of ands and buts in there. So if someone thinks they might qualify, they should apply. Apply and let us determine if they fall underneath that reserve limit, because it's a huge range. It goes up to $137,400 if you're in a nursing home and you have a spouse at home. So it's worth the opportunity to come in, let us look through what you got, and we'll determine if you're eligible. All right, family and children's Medicaid.
All right. Family and Children's Medicaid assists low-income individuals, children, and parents with medical coverage. The children can be covered through age 20 who live alone with one or both parents or with other adults. It also covers parents caring for children under age 19, and this is an eligibility requirement that differs from adult Medicaid for family and children's Medicaid. For family and children's Medicaid, for an adult to receive full coverage, they would need to be the caretaker of a child. And we also have programs to cover pregnant women who with or without other children. And a great program we have that if an adult or if someone is receiving full coverage, we also have auto newborn where their children, when they're born, are covered for Medicaid for 13 months. Okay. So we wanted to provide you some information on the growth that's been occurring in Medicaid. As you'll see, if you look across the applications approved from fiscal year 21 to what's projected for fiscal year 23, there is a decrease. But when you look across the renewals approved, there's a 19% increase across those fiscal years for a total participant increase of 33% receiving Medicaid. This will be an increase in our workload as we return to recertifying eligibility for all Medicaid beneficiaries. And you'll hear more about that on the next slide when we talk about the ending of the public health emergency. And at the bottom, you see the value of the Medicaid benefits that we have for fiscal year 22. We hit almost $1 billion, whereas for fiscal year 23, which we're 3/4 of the way through, we're almost up to 700 million. So what is the value of the Medicaid benefits? That's the total of premiums that are paid on recipients' behalf, as well as any claims paid out by Medicaid. All right, let's talk about the public health emergency. During COVID-19, the federal public health emergency provided North Carolina Medicaid beneficiaries with ongoing Medicaid health coverage. So the renewals of active recipients were getting automatically extended by the state, but with the ending of our public health emergency, states must start recertifying eligibility for all Medicaid beneficiaries. For North Carolina, this is going to begin in April for our renewals that end June 30th, 2023. So for all of those renewals, we will be responsible for determining their ongoing eligibility. The way the renewals work for Medicaid is they're certified generally in either 6 or 12-month certification periods. Customers, unlike other programs, do not get recertification reviews mailed out to them. They are not contacted. We do everything on our end to verify everything online. We only contact them if additional verifications are needed. If no additional verification is needed and we can determine their eligibility, they'll just receive an approval or denial notice. Now, with our family and children's Medicaid, the state has implemented some straight-through processing measures. And the first one you'll see here is that the state is reviewing customers who receive food and nutrition services and family and children's Medicaid to see if they can automatically approve those renewals. If they fall through that, they go to step 2, where they evaluate them using our online verifications. Now, the state was anticipating that they would be able to do 20 to 30% using the automated process. But right now, as you see in February, we saw an impact of 1% go through the straight-through processing. The rest of those renewals will be the responsibility of Mecklenburg County to determine their eligibility. The plus is there will be no lapse in coverage for the customers, because if we don't get to it timely, the state will extend for 1 month at a time, which will allow, if necessary, appropriate notice to the customer for termination of their benefits. Now we're going to move into talking about the Medicaid expansion.
Okay. So I know all of you have heard about Medicaid expansion. This is something that's been in the works for a little bit, and it's on the horizon. We're anticipating it passing with the state budget. Now, North Carolina anticipates it's adding 600,000 new individuals to help with this Medicaid expansion, to benefit from that. For Mecklenburg County, we're looking at 64,000, 47,000 within the first year. These are people that can benefit from the Medicaid expansion. Now, the age range we're looking at is 19 to 64. Individuals that make too much currently for the regular Medicaid, but not quite enough to be able to purchase private insurance through the marketplace. So typically what this is looking like 138% of the federal poverty level. So for a family of 3, that's less than $32,000. Medicaid right now covers 2.71 North Carolinians currently, which is an increase by 27% since the beginning of the pandemic, according to Department of Health and Human Services. Now note, we're at like 33% right now prior to the expansion. Now, this Medicaid expansion, we got this slide directly from Department of Health and Human Services. Who is covered, right, with Medicaid expansion? So we're looking at low-income parents and low-income childless adults. Now, when we talk about low-wage workers, oftentimes they're talking about agriculture, childcare, construction, and veterans and their families, children who age out of Medicaid, and then women who would have qualified if they were pregnant. A little bit more about the demographics. Now, I was a little surprised about this first one, but more than half of the uninsured are under 40. Most are employed, but they have high uninsured rates, like in hospitality, in retail, and manufacturing. 1 in 3 uninsured are parents of children under 18. And then 52% of the low-income uninsured are women. Now, there's lots of ways that you can apply and receive Medicaid coverage. We have 2 offices, one at the Wallace H. Kuralt Center, 301 Billingsley Road, and then we have the Community Resource Center at 3205 Freedom Drive. Monday through Friday, 8 to 5, you can come in, make the application. You can come in and pick up a paper application, mail it back, fax it back, drop it back in our mailbox, right? Or you can apply by phone. You can apply by fax. You can go on the website, the state site, and do the E-Pass application, or you can do it through our All Access. And that's a website, mecnc.gov. You can apply all those ways. Now, Chairman Griffin, that concludes our presentation. I do want to point out you have a handout which talks about all the little different categories of Medicaid. You'll notice it may be a little overwhelming when you first look at it. It's a lot of information. That, I tell you, it's trying to condense, charts that we have that are far more complex sometimes than that, right? But it has the income, it has the resource limit, kind of a little short snippet about what it is. Now, I will tell you that's what it is right now. In April, it's going up about 8% income, right? It's going up. So that'll be coming out. But just want to point that out to you. I don't know if you want us to take questions now or go on to the next presenter and then have questions.
What I'm going to do, did this work for 20 years, so I kind of a little bit familiar with it. But eligibility is kind of squirrely. I'm going to ask my colleagues if they have one burning question.
Okay.
On eligibility, because we have a legislative presentation coming back right behind you, they can ask questions.
Okay.
So I'm going to ask my colleague who's a member of the committee to introduce herself, who has arrived, and then I'm going to ask eligibility that you just heard.
Hello, I am Mecklenburg County Commissioner Elaine Powell. I'm sorry, I was stuck in a one lane only, one lane with the stop sign traffic. So thank you.
All right. A lot of information about eligibility. Questions about eligibility. Commissioner Meyer.
Thank you very much, Mr. Chair. I will be quick. I guess this is under eligibility, but if a person walks into a hospital with an emergency and doesn't have healthcare, doesn't have insurance, is that Medicaid who kicks in, even though they're not actually a member? And then in the long-term care facilities, do all facilities take Medicaid, or is it a certain number of those, or do they have like a cap for each?
Okay, so I will say that if somebody comes in and they need emergency care, in the hospital, then my understanding, they're going to see them. Now, we do have Medicaid workers at our big hospitals around here, so they can follow up. And if there's any way that they can qualify for Medicaid, then we're going to facilitate that paperwork to make that happen. We routinely meet with our hospitals to make sure that that process is running well.
Okay.
All right. And your second question was like all nursing homes.
Right.
And they have to be in a Medicaid bed. And so that's the same thing with our rest homes. Like we have special assistance, but you need to be in a Medicaid bed in order to get that special assistance rate.
So they only have certain number of beds allotted for some of these.
Medicaid.
Okay,
Mhm.
thank you.
By Commissioner Rodriguez McDowell.
Okay. Let me first say thank you for this information. On television, we see a lot of information, a card coming to you. All you have to do is call, but it doesn't specify what the requirements are. And I have a lot of seniors in my district, along with myself. My question is, how do we define low income?
So low income, that's based on the income chart that you have. That's, I know the one with all the charts and all the graphics, but it's a certain percentage of the poverty income limit. So each category will have a separate income requirement for that program.
For the program.
Mhm. It's a certain percentage of the.
Medicaid and then Medicare, we have cards that we get. What's the difference from Medicaid and Medicare?
So Medicare is always going to pay before Medicaid. Medicare is health insurance, just as Medicaid is, but they automatically, most people are going to get it when you turn 65. If you're already receiving Social Security at 65, they may automatically enroll you in that. Otherwise, you have to enroll. Typically, you need to enroll like 3 months after you're eligible to enroll for Medicare. But then Medicaid is for individuals that meet our income and reserve threshold. So for that, there's a chart that goes through, and for this Medicaid expansion, they're also stipulating a certain income is what it looks like 138% of the federal poverty level. So I will mention that if you happen to be above the income, that doesn't mean that you're never, ever possibly able to get Medicaid. There are things such as deductibles that we have. And so if you over the income, but you get a big bill, right? Then you may be able to meet a deductible if your reserve limit is within standards to qualify and get that bill paid. So if someone doesn't have Medicaid and they think, my income's a little bit above that, and they have a hospital bill, and say that was the prior month, they should come in, right? And see about, can I qualify and get what we call retroactive Medicaid and use that bill to meet a deductible. So there's lots of different ways. If anybody is interested, if they have a healthcare need and you're kind of questioning, I don't have a lot of money, I don't have a lot of resources, anything like that, I would strongly encourage them to come and apply. It's worth a visit to come and apply, because there are lots of different rules and policies and exceptions. When I'll count it this time, but I won't count this because your situation is different. And so when in doubt, I'd like you to know, please do apply.
Thank you. I'll come back. I have some other questions too.
Yeah, I mean, as we get near the end, we've got
Right,
time,
okay, I
we'll come back
understand.
and wrap up. Commissioner Rodriguez McDowell.
Thank you, Mr. Chairman. I just wanted to ask about on page 4, where it talks about undocumented folks. And it says, emergency services Medicaid is for non-qualified aliens on the days an emergency existed. So if you're undocumented, let's say, and you're in a car accident that really messes you up and you have an extended recovery, is it only the things that happen on that day, or is everything that's connected with that part of emergency Medicaid?
Emergency Medicaid isn't going to be an ongoing coverage period. It's going to be what the we send it off to a third-party alliant to get approved, but it's gonna be what they deem with the life-saving measures, but not ongoing coverage. So it'll just be, if it's a day or they need those 2 days in the hospital, then it would be to cover that.
Commissioner,
Yes, Mr.
I want
Trotman.
to point out a couple of things that they mentioned.
Okay.
She stated that we have staff that work in the hospitals. The hospitals pay the county share of the staff's salary. So it's definitely not a free thing for the hospitals to have workers in the hospitals. We also have a worker assigned to public health because individuals come there all the time without insurance. We're in conversations with Medic right now because they encounter a lot of people without insurance. So we want to make sure that we get all those folks enrolled in Medicaid that are eligible for Medicaid. But a big expense to the county is inmate Medicaid or inmates that have overnight stays in hospitals. The Affordable Care Act provided allowances for individuals in jails and prisons. Anytime there was an overnight stay, Medicaid was supposed to kick in. The state changed the policy and technology for prisons, but they never changed it for counties. And so we are having to pay the full freight of the bills for any overnight stay for individuals that are in the county jail. That policy went into effect, I believe, in 2013. So 10 years later, and we've been having multiple conversations with the state, but they've never implemented the policy or technology changes to allow us to bill Medicaid for individuals that have overnight stays, like pregnant women or individuals that have multiple surgeries, so on and so forth. And I think the budget for that is several $1 million of for inmates that go into hospitals.
Thank you, Mr. Trotman. That's something you probably asked the legislative representative when she comes up, what's been happening since 2013 to try to improve that. I'm gonna move on to the next unless there are questions. I mean, I got 1,000 questions, but they just nowhere is two things I'll say. The hospitals are required to provide a certain level of community care. That is always under debate about how much community care that they're providing. Statutorily, they're required from a federal perspective because of various investments, loans that the federal government, and when they buy machines, medical machines, it costs $10 million or $40 million. The feds will help them acquire those machines, and as a result of those grants, they are supposed to provide care. So that's an ongoing debate, Commissioner Rodriguez-McDowell. But if there's an emergency, they're required to see folk, and then subsequent care could possibly come from either the federally qualified health centers or other agencies for undocumented residents of Mecklenburg County. But thank you so much. It's a lot of moving parts for Medicaid. I used to look at it being just a right hand and a left hand. If there's a medical need, and if there is the means test, meaning you don't have enough money to pay for it, they need to reach out to the Department of Social Services and then let them work through some of those different programs. But thank you very much for the presentation, and I'm sure that at the end, don't go away. There may be more questions for you. Okay.
All right. Thank you.
Thank you very much. Next on the agenda, Mr. Trotman. All righty. Our legislative expert. Good afternoon.
Good afternoon, Mr. Chairman and Commissioners and our Deputy County Manager and colleagues. I heard you, Mr. Chairman, mention that you have questions for me, so I'll do my best to answer those. This agenda item to talk about the legislative update or perspective about Medicaid expansion, of course, was put in place. The staff does a great job early to put the agenda in place with you, Mr. Chairman. And so since then, Of course, we know the Medicaid expansion bill was passed by the House and the Senate. I had the opportunity to actually be in Raleigh last week when the Senate was debating the final votes on the bill. And it's important to note that I was in Raleigh with our Charlotte Business Alliance as a part of their advocacy committee. And that's important because our Chamber of Commerce, as it used to be known, our business community, they were one of the first in the state as a business group to endorse and really promote Medicaid expansion as legislation and a need for our state. And so they then led the way for other business communities across our state to also advocate on behalf of Medicaid expansion. So it was really special to be in the room at that time and in a meeting, but the vote was happening in the other buildings. So I'll preface my comments with saying that it's been a unified effort with the county, our health stakeholders, and also our business stakeholders to pass Medicaid expansion in North Carolina. So what happens now? Kimberly and Lynn did a great job giving their overview and gave you a primer or a hint to what actually has to occur for us to have Medicaid expansion, and that's for the budget to be passed. So we operate on a fiscal year here in North Carolina, and so that budget should be passed by July 1st. The governor came out with his state budget last Wednesday, as a matter of fact, and his state budget proposed an increase of nearly $5 billion to the state current fiscal year budget. It placed an emphasis on public education with $4.5 billion to invest in school construction and to provide an average raise of 18% for teachers, with every teacher receiving at least a 10% raise for the first year. His plan called for an additional over 1,000 school nurses across the state and personnel like bus drivers and counselors. His budget, the governor's budget, also reversed some of the tax cuts. And this is important. I'm giving you this background for a reason. His budget reversed some of the tax cuts previously passed by the General Assembly. Those include the scheduled income tax deduction for individuals earning more than $200,000. It would also stop phasing out the state corporate income tax. So his budget was robust and responsive to the needs for education, needs for even included some business incentives. He had a robust budget that has to be considered. What were the responses from the legislatures? I have the quotes here just to give you a snapshot. Some of you are laughing, you probably heard them. Senate President Pro Tem Phil Berger, he's a Republican from Rockingham, called the governor's proposal an irresponsible, unserious proposal from a lame duck governor who wants future North Carolinians to pick up his tab. And I'm giving you these quotes not to be partisan, but just to set the record and really just let you see where we are in this process. On the other side, in the House, Speaker Tim Moore, Republican from Cleveland, said, the budget takes the same reckless approach to spending that his fellow Democrats have taken in Washington. So I'm giving you the environment that we're going into. This last stretch to actually have Medicaid expansion happen in North Carolina only occurs when there's a budget passed in North Carolina. And this is the reaction to the governor's budget, which for the record is not abnormal. The legislature, when it's a different party than the governor, often takes a totally different perspective than the one that's presented to them. But the stark differences needed to be pointed out as we talk about what has to happen for Medicaid expansion to occur. So here's what happens now. The House has the first shot at creating the legislative budget. They have started with their negotiations. Then it goes over to the Senate. The Senate has their negotiations with the goal of enacting a budget prior to the new fiscal year in July 1st. Last week, it was announced that the House and the Senate have agreed on their numbers, contrary to the governor's budget, of course, which gives some hope to a budget being passed on time. Some of you all that have been in North Carolina for a while know that we've had continuation budgets and we've gone until October and had a Halloween budget or a Thanksgiving budget before. Our state requires us to have a balanced budget, and they do continuing resolutions, but the fact that they've negotiated numbers tells us something about how they're acting, about where they are. So here's the agreement so far. No more than $29.7 billion to be spent in the coming fiscal year. which is 6.5% above the current fiscal year's budget. That amount would grow to 30.8 billion during the 24-25 fiscal year, or another 3.75% increase. So I'll end with this number in comparison to what the governor proposed. The governor proposed almost 33 billion next year. Keep in mind, their proposal is 29.7, with an 18% increase versus the legislative agreed upon 6.5% increase, followed by a 34.2 billion the following year versus their 30.8 billion. So there is definitely a difference, but the point of the comment is that the House and Senate have agreed on that budget number. And what we know furthermore is that there is only one vote separating a veto, a supermajority. And so realistically, the legislature will pass whatever budget they pass, and the governor will not be able to veto it. And so that's where we are. There are some big issues though that impact the budget in a bipartisan way on both sides. And we talked about those issues during my presentation to the board on your legislative agenda. Those issues include changes to laws related to abortion in North Carolina. Sports betting is such a big issue. NASCAR was in the building last week. But sports betting in North Carolina, immigration control. We saw the bill relating to dealing with ICE come back up with the sheriffs. And I have to tell you, I cringed as some of our legislators talked about their perception of crime in Mecklenburg County and our sheriff. And our sheriff did send a letter regarding that particular bill. Some of the other issues, medical marijuana being passed, or those laws changed in North Carolina, redistricting, those could hold up that budget process a little bit if there are some Republicans and Democrats that are on different sides of those issues. But if I pulled out my crystal ball and my wand, I'd tell you July 1st, we'll have a budget with those particular numbers that have already been agreed upon, and how those numbers fall out for raises to teachers, for assistance with early education, some of the items we really care a lot about, community items. We'll continue to monitor those and work with our delegation. They're hearing from me all the time and from our lobbyists, but I think we can be assured that Medicaid expansion, once this budget passes in July, will happen. And so that is something to be said after a lot of work that our county and so many different stakeholders have worked on for many years. And I think there were 2 members of the legislature that voted against Medicaid expansion. They were not in our delegation. So our delegation is definitely on board as well. So Mr. Chairman, I'm happy to answer any questions about the Medicaid expansion legislation, or if there are a couple of other items with your approval, I can try to speak to those as well.
Certainly. Thank you for your presentation, and thank you for your work. I'll see if there's a quick question on legislation from my colleagues. I do have one, but I'll wait until they ask theirs. So I'll look to my left and I'll look to my right. Is there a quick question on legislation for Mrs. Tanner? I don't see any, but I do have one. There is a poison pill in that budget, and that poison pill is the governor has to approve the budget. If the governor does not approve the budget and goes into this thing that they routinely go through, Medicaid won't pass.
True. The budget would then go back to the legislature. They would overrule his veto, and then we'd have another time frame again. And I would say, and out of respect for you bringing up the governor, he did encourage the legislature not to wait until July, because we have residents of our state that need assistance now. So you're right.
Commissioner Lee?
Yes. I thought I read someplace where that the Senate had passed and they're waiting for the House now.
They both finished just recently. Yes,
When you
ma'am.
say recent, is that yesterday? or-
Last week.
Last week.
Yes.
So clearly say to us, because I'm hoping the public is listening, that the Senate and the House have passed it.
Yes, ma'am.
So what are we waiting for now?
There are funding proposals that are included in Medicaid expansion. So they passed the policy, but the money portion of it will actually happen once the state budget is passed, which will be by July 1st.
It has to be the full budget.
Yes.
And before they deal with Medicaid.
Before it's finally official. Yes. Medicaid.
And my last question deals with homeless. We see on the different sections of this county, can they be taken to the hospital and taken care of through this process, Medicare?
I think with the presentation that our colleagues before, yes, if they're homeless and they need care, they're able to go into the hospital to have that immediate emergency care.
Thank you.
Yes, ma'am.
And I ask that because many of them do have problems, physical as well as mental problems. So if they're not aware that they need to go, then they wait, they're there in our community at the mercy of themselves.
Yes, ma'am.
Because
Yeah.
there's no day-to-day communication.
Yeah,
That's what I wanted to say.
okay, thank you. Any other questions for Mrs. Tanner? But she'll be here, and as we finish this other can of soup about managed care, we'll ask those questions and then come back
Thank
to
you.
some eligibility and legislative questions if we have them. Thank you, Mrs. Tanner.
Chairman. You're welcome.
All right, Mr. Deputy County Manager Trotman, we got one more.
Yes, sir. The next presenter is Robert Nesbitt, and he's going to give you a presentation on Medicaid managed care and the shift that took place a few years ago from fee-for-service to managed care.
So good afternoon, Chairman Griffin and HHS committee members and commissioners. Thank you for the opportunity to present today on Medicaid managed care. So as Deputy County Manager Trotman shared, I'm Robert Nesbitt. I work as Chief of Staff for our Health and Human Services Agency and work with the HHS leadership team on a wide variety of different initiatives across the agency. My presentation today on Medicaid managed care really builds on the presentation given earlier, and it speaks to what kind of undergirds a lot of the different Medicaid services and the shift that's going on at the state level on how services are managed and delivered. So I'll start with answering a question on what is managed care. And that really, for such a broad term, it can be a bit confusing to unpack. It has huge implications across our country and in healthcare, but it's a bit convoluted at times. Managed care is a type of health insurance designed to contain costs while also maintaining or improving the quality of healthcare. Rather than paying for specific services, which is often referred to as a fee-for-service model, managed care plans offer per-person rates to coordinate, manage, and pay for healthcare. These are commonly referred to as capitated or capitation rates. That's a very common term you hear around managed care, or also per member per month rates, PMPMs. And this is different than the traditional way of paying for a lot of healthcare, where someone would receive a certain procedure or service and the hospital or provider would get reimbursed. Managed care is extremely common in healthcare, with some estimates saying as much as 75 to 90% of all insurance plans having some form of a managed care component at this time. Now I'll speak to how all of this relates to Medicaid in our state. And so in 2015, the General Assembly enacted Session Law 2015-245 that directed the Department of Health and Human Services to transition Medicaid from a fee-for-service model to a managed care model. North Carolina's shift to managed care is part of a greater trend nationwide in Medicaid service delivery and management. Managed care is now the dominant service delivery form for Medicaid enrollees across the country. And with as much as more than 70% of individuals who receive Medicaid nationally having some sort of managed care plan. So the shift to managed care has a focus on increasing budget predictability, as well as containing Medicaid spending and improving access to care and value. Now, I will share that early research shows that there has been greater budget predictability for states with the managed care model, but some of the evidence around the impact of managed care to improve access and quality of healthcare is much more limited. And so I think a lot of that still has some bearing out. In North Carolina, all Medicaid managed care health plans are required to have the same basic service array, which would include office visits, hospital services, including inpatient and outpatient components, blood tests, care management, and x-rays, And each health plan has its own network of doctors and healthcare professionals, which you'll hear referred to as the provider network or an adequate care network. As part of Medicaid transformation, the Department of Health and Human Services has 3 phases or initiatives to shift from the fee-for-service model to a more comprehensive managed care approach. And these are called the Standard Plan, the Tailored Plan, and the Children and Families Specialty Plan. And I'll start with an overview of these 3 phases or initiatives, and then I'll talk about Medicaid Direct, which is still that traditional fee-for-service model, which serves a sizable portion still in our community. The Standard Plan is the largest of the managed care initiatives, and it was launched or went into effect on July 1st, 2021. And it serves beneficiaries through 5 prepaid health plans. These prepaid health plans are United Healthcare, AmeriHealth Caritas, Healthy Blue, WellCare, and Carolina Complete Health. The Standard Plan PHPs, so prepaid health plans, is a lot of acronyms, so I'll try to say it out clearly. Offer integrated physical health, pharmacy, care coordination, and very basic behavioral health services. And this model of the Standard Plan serves 2/3 of all Medicaid beneficiaries in Mecklenburg County. So you can see that number of about nearly 200,000 individual beneficiaries under the Standard Plan. And this includes families and children, pregnant women, and people who are blind or disabled and not receiving Medicare. Now, I want to walk through the process of how someone is approved for managed care, because that can be a little confusing. So when a person is approved for Medicaid and deemed to be appropriate for the Standard Plan, NC Medicaid automatically enrolls them into one of these 5 prepaid health plans. And that enrollment, they call it auto enrollment, is based on a person's geographic location, any existing healthcare provider relationships or preferences, which they can share through a Medicaid application, any health plan assignments of family members, and any previous health plan enrollment. So those are just some of the ways that auto enrollment is done. Once a beneficiary has been enrolled in a Standard Plan, the head of household receives a notice by mail that includes their enrollment information and also beneficiary welcome letter, member handbook, Medicaid ID card. So most beneficiaries have the option to change their Standard Plan provider health plan within the first 90 days of their start date. To change that Standard Plan, beneficiaries can contact an NC Medicaid enrollment broker, which if anybody's interested, I can share that number. And after the initial 90-day period, beneficiaries can change their Standard Plan at Medicaid recertification dates or with just cause, which would mean if they've had a poor quality experience with their health plan, they can request to change that health plan and switch to another of the 5 providers. So I'll move on now to the Tailored Plan. And this is the second phase of Medicaid managed care. It's scheduled to launch on October 1st, 2023 with 6 managed care organizations. And these are the managed care organizations that currently serve as the behavioral health MCOs across the state. And it's interesting to note that Medicaid managed care actually first began in the behavioral health world within Medicaid. They piloted this managed care model with the group that was at the time Piedmont Behavioral Health and became Cardinal. So this is kind of where some of the Medicaid managed care was first tested out in the MCO model. Alliance Health is the MCO for Mecklenburg County and became our MCO on December 1st, 2021, after our disengagement from Cardinal Health. And so what makes the Tailored Plans different from the Standard Plans is they have much more of a focus on specialized behavioral health services. They will offer the same basic services as the Standard Plans, which include physical health, pharmacy, and care coordination, but they're really focused on serving Medicaid recipients who have the most complex mental health, substance use, or intellectual developmental disability needs. And so that's what makes the Tailored Plans distinct. I will highlight that we work closely currently with Alliance Health, our MCO, and they work with all of our Health and Human Services departments, as well as the Criminal Justice Services Department for the county. And through this partnership with Alliance, we have seen some early wins. I'll highlight the recently opened Steve Smith Behavioral Health Urgent Care. That was a partnership between the county, Alliance, and Steve Smith Family Foundation. They've also got a new community transitional recovery housing program that's going to be coming online next month, and development of a facility-based crisis center for adults. So I did want to call out some of those projects that are in the works. That facility-based crisis center would open projected in fall of 2025. So now I'll go on to a proposed plan. And I want to be clear that this plan has not yet been implemented or approved by the General Assembly. This is something being proposed by the Department of Health and Human Services called the Children and Families Specialty Plan. And it's designed for youth in foster care with the goal of improving care coordination among service providers, families, and key stakeholders serving youth in foster care, which would certainly include our children, family, and adults department. Now, I will acknowledge there is a challenge at the local, state, and even national level to secure the appropriate residential placement and treatment for youth in foster care who have the most complex needs. And this is something that, going on nationwide. It's something we experience here in the county where we have a challenge of finding providers to serve youth with the most complicated needs. Alliance has been working to secure some additional transitional crisis beds for youth in DSS custody to address this need for those who need therapeutic residential care. And I want to highlight too that the county and some other counties in the state are concerned that this statewide plan would disrupt some of these local projects that we have where we're investing dollars, Alliance and the county, into supporting youth in foster care. There's a concern that a large national healthcare group could come in and bid on this, and it could disrupt the local presence and partnership that we have with Alliance Health and that we have developed. So that is an overview of the Children and Family Specialty Plan. And now I want to highlight NC Medicaid Direct. And this is the traditional fee-for-service model. I didn't want to leave this out of the presentation because it's still a key component to the way Medicaid services are managed. As of March 2023, nearly 100,000 Mecklenburg County residents are still enrolled in NC Medicaid Direct. And even after the tailored plan I mentioned earlier is launched, there will be certain categories of Medicaid recipients enrolled in Medicaid Direct. And that includes people who are dually enrolled in Medicare and Medicaid, individuals who are deemed medically needy, individuals who are on family planning Medicaid or limited Medicaid packages, and a PACE program, which is an all-inclusive care program. So those are just some of the examples of individuals who would remain in the fee-for-service model. And in closing, I just want to highlight a few of the care management programs that are under Medicaid managed care. Two of these are operated by our public health department. It's care management for high-risk pregnant women, also commonly referred to as SIMHARP, which is a resource for pregnant women with various risk factors to receive a coordinated set of clinical maternity services. The program is designed for women who receive Medicaid managed care, but also they accept pregnant mothers who are on NC Medicaid Direct or maybe Medicaid eligible. Women receive services throughout pregnancy and for 2 months after delivery of their child by either a social worker or a nurse. Services include helping mothers gain access to maternal health care, helping connect mothers to social determinant of health resources such as housing, food, utility assistance, transportation, advocating for the mother in healthcare settings. And in FY 2022, the SIMHARP program served 1,820 pregnant women. I also want to highlight somewhat of a sister program for SIMHARP, CMARC, Care Management for At-Risk Children, which provides services for children birth to 5 at risk of developmental delays and chronic conditions. And these are children who are at risk or diagnosed with a long-term physical, developmental, or behavioral health condition. The CMARC teams help parents and children navigate the healthcare system and identify community resources to have healthcare needs addressed. And in FY22, CMARC served 2,258 children, our program did. And lastly, I'll highlight non-emergency medical transportation, which is also called NEMT. And this is the standard transportation plan for folks in the standard plan of Medicaid. And those prepaid health plans coordinate with transportation brokers to offer this service to any Medicaid approved treatment. Our Services for Adults division in the county provides this resource to NC Medicaid Direct recipients, and last year provided more than 295,000 trips to 21,099 individuals. And so we are still assessing the impact of Medicaid managed care. As you can see, there's a lot to unpack with this initiative, or these multiple initiatives. But that will conclude my presentation for today. Thank you, Chairman Griffin and commissioners, and I will be happy to answer any questions.
Nesbitt, thank you for your presentation. I will look to my colleagues. This is another Medicaid program with many, many different parts in terms of managed care. So let me see if my colleagues have questions. I'll reach. All right, Commissioner Powell, and then Commissioner Meyer, and then Leak, okay? In that order. Commissioner Powell.
Thank you. On slide 4 of your presentation, you said that 197,000 Medicaid recipients were enrolled. I was doing the math, and that is 27% of our population.
Right, so there are approximately, and the team here can be precise, approximately 330,000 individuals currently receiving Medicaid in Mecklenburg County. And trending up even more. And so, yes, so it is a sizable number, and most of those are under a standard plan model now.
Is that an abnormal proportion for a county?
It's a good question, and no, I mean, based on my awareness, it is not. It's often you see a quarter to a third, and Anthony, I don't know if you want to add to that, but it's not unusual for a county of our size.
That's correct. About 25% in many of the large metropolitan counties.
Say that again.
About 25%, what I've seen throughout the country.
But we're higher.
Yeah, we are higher now. And I believe we are higher because the state limited, well, we were not doing recertifications. And that's one of the things that they touched on. And so part of the recertification process is to look at their assets and income. Some of those individuals will fall out. They will not be eligible moving forward once we look at their income and other eligibility information. So it will go down, but many of those individuals will qualify for Medicaid via Medicaid expansion.
And do you have any idea, you said, or in one of the presentations, it said we expect like 600,000 more people to be eligible?
Throughout the state.
Throughout the state. Do you have an idea for Mecklenburg County?
Yes, it's around a little less than 70,000.
Okay, and we're expecting like 47-ish the first year?
Yes.
And what I did not understand, because you went through it so quickly, and I know you guys work together, on slide 12 of the other presentation. What kind of safety, I think it's slide 12. What kind of safety net is there for, maybe it's slide 13, making sure that when there is expansion, how are we going to manage that with?
That's a good question.
Yes, it's a hurdle, isn't it?
Yes.
We are, as we go through the budget process, we are working with the manager to increase staffing in this area. We are concerned that we don't have the capacity. We currently have around 40 vacancies. So, and the staff have around 70 interviews to fill those 40 slots. So it's going to take some time for us to get there, but we are pursuing a big increase in staffing. And one of the things that they said with Medicaid expansion is that the state would reimburse us 100% for employees to process those expansion cases. So as part of the budget process, you'll see an increase in this area moving forward.
Justifiably. Like
yes,
right.
Absolutely.
And so I just, one more real quick, Kimberly, you said we're at 33% in Mecklenburg, but is this 33%? What were you referring to?
It's participants in Mecklenburg County that we have on Medicaid.
So 33, it's way higher than 25. That's a remarkable. Thank you.
That's.
Oh, and so the projection, because we did fiscal year 23 projection, so the projection's 33, but we are As you see, it goes up in fiscal year 21. We were at 270,000 and we're projected to be at 358 by the end of this fiscal year.
You guys look really good for all that stress.
Commissioner Meyer?
Thank you. Okay, this is confusing to me. I think it's total bureaucracy to me, the way I look at it. I mean, do you guys have cheat sheets that you have to look at to figure out
Yes.
care plans? And I mean, it's just boggles my mind.
The training alone for Medicaid is multiple weeks. And so when he mentioned we're looking for more staff, we're really looking to bring them in a lot earlier because it takes many months, honestly, for them to be proficient and able to perform because the policies are very complex. They're very detailed. Little things mean the difference whether you qualify or not. And we want to keep our quality high. And so therefore, it is, the chart you see is a very simplistic chart of what we'll do for each one of the categories. The manuals that we follow are, thousands.
Yeah, I was gonna say they must be huge. So the coordinated set of, okay, youth and foster care, the children and family specialty program, that you said it's not quite implemented yet, correct?
That's
What
right.
what do youth and foster care do now?
Currently, youth in foster care receive connection to care through Alliance Health. So they are still receiving NC Direct. So they are still on that fee for service model of Medicaid, the traditional model, and their behavioral health services are covered by Alliance Health.
And so right now, so they're waiting to be directed to this new program. If it
Yes,
gets
if it's approved. But we have voiced concerns about aspects of that plan and again, potentially losing that local connection to say a partner like Alliance.
Okay, and last question, I mean, I have a lot of questions, but
Sure.
the last question I'll ask now is, so in public health, number 8, slide 8, Medicaid managed care programs, all of these are operated by public health. So when public health, so these are Medicaid plans, right? And you get public health or the county gets paid by Medicaid, federal government, state?
So it's now it's the managed care organizations that Robert talked about. So it's a service for Medicaid recipients that we provide, and we're reimbursed at a per member per month rate for the number of members that we provide service to. But for SimHARP is the number of women that they have on their roster that's eligible for the program. And so we have a contract with every one of those independent insurance companies, Healthy Blue, et cetera. And so every month we receive a payment from them for the women and children that we have in our care.
Okay. Okay, I'm just
Oh, to make your head spin.
kind of fuzzy right now.
Commissioner Leak and then Commissioner Rodriguez McDowell. Commissioner Leak.
Thank you. This is why you hear me talk about poverty in Mecklenburg County and the research that has been done that we talk about. If you're born in poverty in Mecklenburg County, you stay in poverty. That's number one. And when we hear people raving and saying, we got to do this about this process and that process, we have to look at again, and that's why I talk about education so much. Everything cannot go to the school system. This budget that we have to come up with, we're getting a real picture of what the problem is in Mecklenburg County. And with the growth that we have coming in now, it's even more so than what it was even 5 years ago. And to train people to take these jobs, it takes money to do it. And when people do not vote for a budget and yet travel on a budget, I have a real problem with that. The realistic process is what we're receiving. And if you don't vote on a budget, there's nothing out there for the people to have. But yet you are the recipients of those funds when you come in to a community, no job, nowhere to live, and the county has to take on the responsibility of taking care of those who cannot take care of themselves. And that's a real picture. Am I right? Or am I wrong? Am I looking at it wrong?
All right.
Money
Commissioner
does
Leak.
not grow on trees. And we can't travel if we don't or vote for a budget, you shouldn't get anything. If you vote for a budget, those items that we talk about, we can talk about it. So I'm not upset about it. I'm concerned about it because there's not money for everything that people come for us for. And we have to skim on some areas and spend on another area. I asked to see the travel of county commissioners to see how much we are spending, not just one person, 2 people, but the board spends for travel. And that's information that the public always gets, not just getting it this year, but we've always disseminated that information in this county. So I needed to say that poverty is with us. And until we do a better job with education and other areas of training and living, we're going to keep it that way.
Thank
So
you.
thank you.
Thank you, Commissioner Lee. Commissioner Rodriguez McDowell.
Thank you, Mr. Chairman. So one question that I have is, I think, Anthony, you mentioned that the state is supposed to pay for the increase in the necessary workers that have to be hired in order to manage all of this, right?
According to a conversation I had with HHS, they communicated that funding will be available to pay 100%. Right now, it's like a 60-40 split. We pay 40%. But for this Medicaid expansion population, they would pay 100%.
So
Now,
it's just the expansion part, not the
just the-
previous part.
Just the expansion part.
Okay, so this really sounds a lot like the way we pay our teachers, where some of them are hired through, state funds, some of them are hired through county funds. And so then we have to offer a supplement because nobody wants to work for those wages and come to our county. Is it going to be the same kind of thing where we might have to start paying supplements to these folks that are paid? And is it federal or is it state? Is it
It's-
coming?
It's a portion of federal and state
Okay.
dollars. And so when we hire these folks, they'll be county employees.
Right.
And there's different agreements for different programs. So FNS has a different split. Medicaid has a different split. It just depends on what the program is.
Mhm.
So it's something that we are used to, managing these different pots. But we definitely welcome 100% funding for staff.
Mhm. Oh, for sure. Yeah, I just wonder with the, the shortage that we already have, it seems like, naturally, we're going to have to, like, if you pay them, they will come, right? If we
Yeah.
want to fill these positions, we have to pay more than other places that are also hiring. And so it seems natural that somehow it's going to fall on us to pay more. And I'm just concerned about that. And secondly, I'm concerned about, the portion that really should be our hospital systems, their portion. And I just get super concerned about these hospitals that have, so many billions in their reserves while we're over here, parsing out dollars for workers. And so I'm just concerned about that and how are we able to measure, that just seems.
I mean, our staff that work in the hospitals, it's a huge benefit to them. They pay us the county portion of the salary, so we don't pay anything for those staff. But it's still a huge benefit to them, especially when it comes to like level 1 trauma centers, where there's a lot of uninsured patients that come in that are potentially eligible. Once Medicaid expansion happens, I would imagine that we'll be able to catch a lot of people and help them become eligible. Once they're eligible, depends on what program, they have access to a full array of benefits, vision and dental and the like. So it's a good thing that we're there and we're right there at the point of, them interacting with the system so that we can process them immediately.
Well, I think what Commissioner Meyer said about bureaucracy is, like an understatement. This system is so incredibly complex that I just think that it's ripe for abuse and it's ripe for I just find it extremely concerning that, that we're not, that our taxpayers aren't being, taken, for a ride here. So, I mean, I don't envy you guys having to work with this program. And Anthony, I don't know how you can even sleep at night. But this just it is really concerning and confusing. And I just want to be someone as a commissioner who is looking out for the public's interest and making sure, I want to know how I can best serve the public in light of this complexity. And so I'm not quite sure how to do that. Just call Anthony. Okay.
Thank you, Commissioner Rodriguez McDowell. I have just a comment and a question. You probably saw the email we got from Adrian Cox. I asked for some basic information about funds coming into Mecklenburg County on behalf of our needy citizens.
Yes.
And if you add up what the transfer payments are regarding housing from HUD, what you get in terms of social services, when you add up the community development block grants and the various programs, poor people economic benefits for this county, somewhere between $3 and $5 billion a year. So Commissioner Rodriguez McDowell, in terms of return on investment, those dollars goes into our community, but they don't go for poor people. They go into our institutions, whether the medical institutions, our corporate institutions, et cetera. And so, I really get concerned sometimes when the relationships are inverted, where people aren't getting their fair share. And I recall back in 1977, back in the old days, the first Leadership Charlotte class that I participated in, there were a number of licensed physicians. And one of the concerns that we talked about in 1977 was managed care, something called HMOs was coming up, et cetera, which is managed care. And we did an analysis there, and managed care was just a functional way of trying to increase profits in the healthcare system. So it's been with us for a long time, but we have to try to do the very best we can for the people that we serve. Some of the plans, this is a relationship between the state of North Carolina, though, and the providers. It's not a local, we're not really involved other than the administration of these various programs. The state signs these contracts, and then we have to figure out how to administer it and provide services. One of the contracts, I can't remember now, I was reading, because I get kind of nosy, and one of the contracts has funds in it because of obesity as a general issue. Children have $150, and maybe you guys know the name of the company, but $150 a year you can get from membership to Boys and Girls Clubs or YMCA. However, very, very few youth and the families take advantage of that. And so what happens to 150, 200,000 times $150? That goes back to the companies because they're saving the state or saving money. So it's a profit when people don't use the service. So when we talk about Dr. Washington, folk are eligible for Medicaid, but they don't have a good relationship with the PCP, et cetera. Under managed care, the corporations reap the benefits because it's a static.
Assuming the person stays out of the hospital.
Yeah. So I say all of that to say, let's, for the role that we play in terms of human services, let's try to help educate as many of those eligible individuals to take advantage of those services as much as they can, so that they can benefit the quality of life for the recipients. So our work is on the education side and really pushing the utility of a lot of the benefits in some of those managed care programs. All right, we are at 2:16. If there is a burning question, because Well, let me back up. We are at the end of the agenda with the exception of some questions, but I want to call on Mr. Trotman to see if there's something that we missed before I ask my colleagues if they have one last burning question before we ask for adjournment of this meeting.
Yes, Dr. Washington had one thing to share, and then I have one thing to share.
Sure. I was just going to add that there is a statewide pilot with the managed care process that is underway in some counties, but not yet in Mecklenburg. It is as a part of transformation to help support some of the, address some of the social and economic sort of barriers that prevent people from accessing care, as well as some of the social determinants that people experience that influence their health. And so the pilots are in some counties now, but we do expect in the next several years that they may scale to the entire state. So it will allow for reimbursement from Medicaid for things like community health workers, for additional wraparound services for families, regardless of if they're a high-risk pregnancy or a kid that has some advanced healthcare needs. As well as will pay for additional incentives for transportation, as well as food. So that's on the horizon, but not yet here.
Well, anyway, I don't want to eat up all the time. Let me see if there's one burning question from my colleagues. Commissioner Powell.
On slide 6 of Robert's presentation, you don't have to jump up. You said you're concerned that the plan would disrupt local projects. Do we have any dialogue about our concerns?
With the state?
Yeah.
Yes, we do.
So maybe Starla wants to answer.
I'll pass that.
What was your question? I didn't hear you.
On slide 6 of Robert's presentation, he said Mecklenburg County is concerned that the plan from the state would disrupt our local projects and not address North Carolina's provider capacity issues.
I didn't hear you.
And this is related, Commissioner Leak, and confirming, please, Commissioner Powell, to the state foster children and youth foster care plan and the concerns that Robert noted on the slide. I'll give you a little bit of background. The bill, the attempt to create a statewide plan started last year. Interestingly enough, on the day that we were in town or you all were in town, I had COVID, that the county was in town for our legislative advocacy day with the North Carolina Association of County Commissioners. And it was scheduled for a hearing that week. And so the commissioners, as well as county manager, deputy county manager, voiced our concerns to the delegation at that point. Also to officials with the Department of Health and Human Services for the state and other leadership. Wake County also expressed their concerns, kind of on all hands on deck to say that we were concerned about this. And especially at that time, we had just switched our LME CMO provider. Our concerns were heard. One of the main concerns was the opportunity for counties to opt out of the statewide plan. Mecklenburg County had been told, as others, by an official that there would be an opt-out provision. The legislation rolled out and it was, well, we don't know if there'll be an opt-out provision. And our delegation felt a little blindsided, and we explained to them that we hadn't complained about the bill because we were planning to opt out. But since our ability to not join the state plan was being taken away, we were concerned about the bill. So the bill was taken off the calendar. It did not continue. We did a great job advocating. This year it's popped back up. Here it is again. It's being considered by the General Assembly, where we know that there's not an opportunity to veto the bill or to do anything about it. And so we've been trying to encourage our delegation to still voice concerns. A letter was hand delivered to them. I'm expressing our concerns about the statewide bill. So we are communicating with our delegation. That letter was delivered by our lobbyists that we've contracted with, hand delivered. I'll be sending a reminder email, but I have to share with you that our delegation has been supportive of the legislation, despite our concerns. So, and this is the question that's asked, because in the committee hearings, what I've heard, and I've listened to them as well as Deputy County Manager Trotman and also Robert and other folks, we hear the stories about children sleeping on couches in emergency rooms. And what they've asked is that happening in Mecklenburg County? Because if you fixed it, then sure, we'll try and give an opt-out provision. And we can't, what we can say is that Mecklenburg County has significantly invested with our LME CMO. We have agreements that we put in place they're really unmatched. Maybe Wake County as well, Wake and MEC and Deputy County Manager Trotman can add to this. What we've done is really unmatched with the rest of the state. However, we're being subjected to a statewide plan. So it's not a good comparison to say, do we also have the problem? Because we've taken additional measures to create our own solutions with these partnerships. So I've been explaining that to our delegation. The bill is going to pass with or without their support, but I've tried to share with them why they should be concerned about Mecklenburg County. They've shared that they're concerned about the statewide approach to this issue. And so we're continuing to talk with them. It's not often that our delegation is not on the same side that we're on, but in this particular case, they are not. Did I cover everything?
Yes, you did.
So please let us know how we can be fierce and help on this.
Absolutely.
This is scary.
Well, I want to thank my colleagues for your attention to detail. This is an extraordinarily important topic, which is healthcare and the access to healthcare. I think when I called each of you earlier, I remember Commissioner Meyer, one of your primary concerns was access to primary health care. Certainly, this is a topic and an issue that will give you some opportunities, but it's the utility of the opportunity as Medicaid expands in North Carolina. So thank you all for your attention to detail. We're finished our agenda. Is there a motion that we adjourn? Is there?
I have one point clarification to make as far as the structure of this work.
Okay.
The last DSS director was here, John Eller. One of the reasons that he said he was leaving is because he was overwhelmed with the amount of work under DSS. And so what I've done is I've kind of changed the structure some. In the Economic Services Division that you heard from today, I moved that under Director Yolanda Griffin. She started her career 20 plus years ago as an economic services worker. And I'm thrilled that she's taken on additional responsibility to lead this work. And so the remainder of the department, you've heard a term called Child, Family, and Adult Services. So YFS, Adult Services, Clinical Contractual Services, and right now the Early Childhood Education will be up under a new director that I'm trying to recruit. So both departments will have kind of equal amount of people. DSS original had around 1,350 employees. With Medicaid expansion, we're looking to add in another 100, 150 employees. It would have been like 1,500 people under one director, and it was just too much. It would have been the largest department in the state. And so now both departments will be around 700, 800 people, similar to public health. And so we're just right sizing these organizations. And we're also maximizing the federal dollar because Director Griffin's department was like 100% county funds. Now with this change, we'll be able to draw down federal and state dollars to pay for the staff in Department of Community Resources.
Sounds like a winning combination and formula, Mr. Trotman.
Yes, sir.
I hope Yolanda got a big raise.
All right, Commissioner Leak, you had a motion.
I made the motion. It was
I
passed.
second it.
All right, it's been properly moved in second. Any discussion? Hearing none, all those in favor say aye.
Aye.
All right, the meeting is adjourned. Thank you very much. Great meeting.
How do we disseminate this information to the public? I want some more of these.
I get with Trump.
I'll
Yeah,
get with Trump.
Trump can do that. The key thing that we need to get people to use it.
Oh, it's-
They make it so.
It's almost like on purpose, so people don't.
No.